a chief complaint of any of these, consider early correct placement of your 4 leads, right? Okay. We're going to consider it when patient has an arrhythmia that's either stable or not, pulmonary edema, cardiogenic shock, diabetics, and post-cardiac arrest. Can anyone see this? Yeah? Okay. I messed with the color not too long ago, but. Okay. When do we not do a 12 lead? So obviously trauma. There's a couple others. Code. Yeah.
Psych cases.
Exactly. Psych, uncooperative. If they're not going to let you, don't do it, obviously. Okay. All right. Now let's get into it. So now we know when we're doing it. Okay. So when we're looking at a 12 lead, when we're looking at any ECG rhythm, essentially what we're doing is reading the electrical impulse from one point to another, right? So even though we have a 3 lead or 4 lead, we're essentially reading between a negative and a positive point. Okay, so always between 2 points. Okay, that's called a bipolar lead. Okay, if you have 2 patches, so let's say patch here, this is standard lead 2, right? We're reading between a negative and a positive. Okay, or if you have a unipolar lead, which we'll get a little bit more into this, if you have a unipolar lead, you're reading from still 2 points. It's an imaginary point in the heart and a patch. Okay, so the heart itself we can consider as the negative, and then the patch, wherever it is now the positive. Okay, it'll make more sense when we look at it later. Again, we're always looking between a negative and a positive lead, always. Okay, standard 3 lead setup. Okay, white over right, smoke over fire. What are we missing on this? What's that? Yep, missing that. Okay, why does that even exist? Why does that matter to have that 4 lead? If we're only reading between 2 points, if we're reading between a negative and a positive, why does it matter that we have 3 or 4? That's one reason, so you can see other views. What does that 3rd patch or 4th patch do when the other 2 are actually in use? It's nothing more than a ground. It's a ground, so it decreases artifact. Okay, so when we're reading between, say, here and here for lead 2, this one right here is a ground. So it decreases artifact to get a more clear picture. That's it. Okay, when you add this 4th one here, you further decrease the artifact and get a more clear picture. That's why we went to a 4 lead instead of a 3 lead. Okay, okay. This is where you guys can reference your perfect 12 lead that I gave you guys to see if it makes sense, and feel free to make notes at any point if you guys need to. This is what's happening with the electrical impulse in the heart and why it's represented the way that it is on a standard ECG or on your 12 lead. Okay, so we have our negative lead, we have our positive lead right here, oops, positive lead right there, and then we have our ground. All the ground does is decrease artifact, makes it a more clear picture. That's it. Okay, so we're looking at the lateral wall. Doesn't really matter. This is where I'm assuming you guys all have a really solid grasp of the cardiac electrical physiology, so we're not going to talk about the SAAV, bundle test, we're not going to talk about that. We're just going to simply say the electrical impulse moves from the top to the bottom. Okay? So we are looking at the electrical impulse moving through the heart this way, and when the electrical impulse moves towards the positive lead, you're always going to have a positive deflection. Okay? So we're moving from a negative lead to a positive lead with the electrical impulse moving towards the positive, so lead 1 should look that way. Make sense? Okay, the electrical impulse is always moving towards the positive lead, so it should be positive. If, for some reason, it's not positive and you have a negative deflection in lead 1, you now have a right axis deviation. Okay? It could be caused by 100 different things. Could easily 10 different things. It could be caused by pulmonary embolism. It could be caused by right hypertrophy. For us as paramedics out in the field, it doesn't matter. If you have a negative deflection, they have a cardiac history. That's it. Okay? So that's kind of one of those little life hacks or paramedic hacks or whatever. If it should be up and it's down, they have a cardiac history. And we've all encountered those patients who say, no, I don't have a cardiac history. But if it's a negative deflection, they do. They do. Okay, lead 2, same thing. We're going from a negative lead up here to a positive lead. down there. The black lead now becomes the ground, decreases artifact, that's all it does. Which way is the electrical impulse moving? Towards or away from the positive lead?
Towards.
So how should it look?
Upward inflow.
Lead 2 should always look that way, okay? If for some reason it doesn't, you now have in lead 2, you have a left axis deviation. Again, a whole new set of problems can be caused from 10 other different things, right? Left ventricular hypertrophy. Honestly, it doesn't even matter that much to me. I don't even know. So, fact is, they have cardiac history. That's all we need to know, okay? It's not going to affect our treatment, our protocols and everything. It just tells us they have a cardiac history. That's it, okay? Lead 3. We have our negative, we have our positive, we have our ground. Electrical impulse moving towards or away from the positive. So it should look how?
Positive.
Yep. Perfect. If it doesn't in lead 3, what do we have? That's it. Left axis deviation, cardiac history. That's it. That's all you need to know. AVR, AVL, and AVF. Augmented ventricular leads. Augmented unipolar leads. Okay? Is basically what it means. Okay? So AVR, this is where we're talking about the unipolar leads. And when I said we're talking about unipolar leads, we're talking about the heart being the negative and the patch being the positive, right? Because we're always looking between positive and negative, okay? Pick an imaginary point in the heart, and that now is our negative lead, okay? So, essentially, we have 2 grounds, right? AVR is our positive. The electrical impulse in this situation with AVR is the electrical impulse of the heart moving towards or away from that positive lead. The electrical impulse of the heart.
It's moving away.
Moving away from that positive lead, right? So AVR on your paperwork right there, is it positive or negative?
Negative.
It's negative, and it should be negative. Because when you look at the electrical impulse, it should always look that way. Okay? So AVR should be negative, have a negative deflection. That's good, that's positive. Here's the catch. If for some reason AVR is positive, if it has a positive deflection, which direction is that electrical impulse coming from? What's that?
Ventricles.
It's coming from the ventricles. It's moving across the heart towards that positive. So if AVR has a positive deflection, most likely you're looking at VTAC. If you're looking at VTAC, you're going to see it in all leads, and you're probably not worried about AVR, right? So based on that, AVR is useless, and that's why you have a big X on that little card that I have there. Of course, you guys are going to find articles that go far more in depth than what we do as paramedics that are going to say AVR is absolutely an essential lead. You have to look at AVR. It's going to tell you a bunch of stuff. For our purposes out in the field, AVR doesn't matter. Okay? Okay, AVL. The augmented unipolar on the left. So, imaginary point in the heart. Negative, we go to the positive lead right there, left side. Electrical impulse moving towards or away from that positive. Moving towards it. Let's say it's moving towards it. So AVL should look positive. Does that jive on your paperwork there? Good. Good. And if it doesn't, what does it tell you?
Cardiac history.
That's it. That's all we care about. Okay? We're going to be treating that patient's signs and symptoms. We're not going to be treating their cardiac history. So it doesn't really matter for us. Okay, AVF, same deal. We have negative in the heart. We have a positive in the left lower, moving towards or away. So it should look, how should it look? Perfect. So all your paperwork looks that way? Good, everyone got the same one. Okay, if it doesn't, cardiac history, that's it. Okay, so brief little introduction of the electrical, why it looks the way it does. Okay, so when we look at placing the patches, we're going to kind of go into a little bit more why it's important to place it properly, but it drives me crazy when I see people just really sloppily putting the patches on there, just kind of where they think it needs to go without palpating and looking at the correct landmarks. It drives me crazy because when you look at the patches, they're specifically designed to pick up the electrical impulse from a specific location, right? So each patch kind of looks at a certain part of the heart and they all overlap each other, right? They all kind of cross each other just a little bit to make like a nice cross section of the heart, okay? When you incorrectly place those patches, now all of a sudden you're looking at a different part of the heart than you want to be looking at. Does that make sense? So one of the reasons that you're going to get false positives out in the field is incorrect lead placement. So that's why when you guys are working with your EMTs or you EMTs as well, like make sure that you properly place the patches because it's really, really, really important. So we have all of our view leads right here, V1, and you guys know the locations. We don't need to cover it. You want to go over it?
Let's go over it.
Okay, perfect. So V1 is where I typically start. Okay, fourth intercostal space, just to the right of the sternum. So you palpate, right, find your sternum, go fourth intercostal space. For me, it's right about here. Immediately, directly across, that's V2. My personal feeling is I go to V4 next, so mid-clavicular, fifth intercostal space, drop it right there. And then right between 2 and 4, right in between it, I put V3. Right there. V3 doesn't matter if so much if it's on the rib or not. It's just directly between 2 and 4. Okay. The rib cage, because it starts going up, we're going to follow the fifth intercostal space. I typically, little life hack, little cheater, I find the armpit and I drop V5 in the fifth intercostal space right at the armpit, and then mid-axillary, V6, fifth intercostal. So one of the common things that I see out in the field with some of our guys even is that V4, 5, and 6 are like a straight line right there. Is that proper placement? No, because the rib goes up this way, so we're not capturing the part of the heart that we actually want to see with the lateral leads of V5 and 6. So we have to properly place it. Okay?
Charlie, what do you think about placing it on the bone or on the muscle?
Through the muscle or the intercostal spaces, or is that what you're getting at?
Yeah.
Yeah, I think that's probably a little bit more appropriate.
Okay. I've heard of bone placement if you're getting a lot of tremors, like artifact from.
If the
tissue.
patient is tremoring or if
Yes.
Hmm.
That's just what I heard. I was like,
I
I've
haven't
never
heard that. And feel free to bring that stuff up to me because I want to learn this stuff too. So I haven't heard that, but if it works, good.
How do you typically try to position the patient when you're doing your 12-lead stuff? You like to have them, more or less at a 45-degree angle, lay them down if they can tolerate it, or is that
Correct. Yeah, exactly. So what they say is you when you're doing serial 12 leads, always have them in the same position. We know that's not always possible, right? So in the same position for serial 12 leads, the best position is supine. Second best position is like 45-degree angle. When we do serials, just try to keep it the same if we can. I know that's not possible, but if you can, that's kind of, so supine is best, I guess is the short answer. And then we're going to introduce, I guess you guys are already familiar, but we're going to talk about V4R as well. So V4R is nothing more than the right-sided V4 lead, exactly the same location, fifth intercostal space, mid-clavicular, just right here on the other side. Okay, so we'll talk about that a little more. Okay, and to beat a dead horse, we're going to look at that. So again, I go V1, V2, V4, I drop V3, and then go 5 and 6. So even my little animated drawing here is incorrect because it should be going up, right? This one, I started off by putting in as a good example, and then I realized there's something wrong with it.
Drops down.
Yeah. There's two things wrong.
Yeah,
There's V3.
look at V1 and V2 too.
Yeah, it's pretty ugly, yeah. So we could probably clean that one up a little bit. Okay, so when we think about 12 weeks, and this next portion here is nothing more than a reminder to you guys for proper placement. Okay, once again, when we look at the location of the leads here, you can see that each lead looks at a specific part of the heart. Okay, so if that lead is improperly placed, we're not looking at the part of the heart that it's designed to look at. Okay, so when we look at the V1 and V2, we're mostly kind of looking at the right side of the heart. V3 and 4 is kind of the anterior, so the front part of the heart, right in the middle. Okay, and then V5 and 6, we're looking at the more lateral side on the left ventricle. Okay, so again, make sure the people you're working with are properly placing it. Okay, it is harder said than done. Yeah, yeah. Okay, so this is where you guys might want to pay attention to your paper. And we're going to take you back to paramedic school and we're going to tweak it just a tiny little bit. Okay? So, electrical impulse of the heart. We know it goes from the SA to the AV, it's held for a second, and then it's released from the AV node, right? Okay. What I was taught 10 years ago in paramedic school, and I think it was probably just like a quick rule of thumb, just to kind of teach it to us really quickly, was that electrical impulse comes down the AV, out of the AV node, down the bundle of His, and same time goes right down the right and left bundle branch, right? You guys remember that? Was anyone taught anything different? Okay. That's not exactly true. And I'm going to show you why, and you're going to see it on your paper. It's not exactly true. There's a brief pause before it goes down the right bundle branch and depolarizes that right ventricle where you get the nice little contractions. There's a brief little pause, and you guys are going to see it on your paperwork here. Okay, so. Okay, so this is what the leads look at. Here's what happens with the electrical impulse. Okay, comes down like you guys all know through the AV bundle His, then it goes down the left bundle branch. Okay. Again, I was taught it goes down simultaneously. It actually doesn't. So we go down the left bundle branch, and then the electrical impulse moves across the interventricular septum. Just the big piece of meat that goes right between the left and the right ventricles, right? Comes across, it hits the right bundle branch, follows that nice clean little highway, and then zips through the right ventricle and then contracts it. The electrical impulse continues back to the left ventricle. So that's what happens, okay? Here's how it's going to look on your paperwork. Okay, goes across the interventricular septum. Okay, when the electrical impulse is moving towards a positive lead, what do we see on your paper? Positive deflection, right? Okay, so as the electrical impulse is moving across that interventricular septum, we get a positive lead, or a positive deflection in leads V1, 2, 3, and 4. Okay? What happens in V5 and 6? Are we getting that? Which direction is the electrical impulse going? Exactly. It's going away, so you get your negative deflection. Okay? So that's why V5 and V6 will typically have a little Q wave in front. I'm not sure if this one does. If it does have a slight one, then good. Sometimes it won't, and again, sometimes it won't because of improper placement or because of the intensity of the electrical impulse at the time or whatever. But it's normal to have a little downward deflection in V5 and V6 because of that electrical impulse. Okay? Let's continue on. Look, electrical impulse now is moving which way in V1, 2, 3, and 4? Towards or away from the positive?
Away.
It's moving away. So how should it look? Is that how yours looks? Good. So does that make sense? V1, 2, 3, and 4 should look that way, right? So now what happens in V5 and V6? The electrical impulse is moving towards the positive, so what should we see in there? So that's how your lead should look in a normal healthy heart. Okay? There you go. And that actually should say V4 right there as well. But. Okay, so what we call, well, this right here is called the R wave. V1, 2, 3, and 4 has an R wave. Remember that positive initial deflection was the electrical impulse going where?
The septum.
Where was it moving through?
Wasn't it going down and across
Across what?
the piece of meat?
Yep, the piece of meat, the interventricular septum. So just the little piece of meat right in between the ventricles, right? So that's the R wave, okay? It's going to be important later on. The R wave is a good thing. So if you have an R wave, that means the electrical impulse is moving through the heart correctly. Okay? Okay, it's a good thing. So we have a good, solid, well-working septal wall. Okay? Because the electrical impulse is moving properly. Okay, let's say, for example, you don't have that. What would that tell you?
Infarct.
What's that?
Infarct.
Possibly an infarct. Yep. So it means you don't have a proper.
Conductive path.
Exactly. Thank you. Yeah, exactly. So the electrical impulse isn't moving through that septal wall properly, right? So that wipes out that little R wave that you have. Okay? Simple. If, like Nick was saying, if you have no R wave and you don't have an ST elevation in V1, 2, 3, and 4, that means it's an old, infarcted, dead tissue. So because that tissue is dead, the electrical impulse isn't getting through. Okay? If you don't have that same R wave in V1, 2, 3, and 4, if you don't have that R wave and you do have ST elevation, that means that tissue that should be conducting that electrical impulse isn't, and it's currently infarcting in front of you. Okay? So that R wave is actually pretty important because it does tell you a little bit about the location of where your heart attack is occurring. Does that make sense? Yeah? Okay. So essentially when we look at V1, 2, 3, and 4, if you don't have an R wave, that's indicative of anterior septal with the septal wall involved. Okay. So looking at V5 and V6, the electrical impulse, we already talked about this. You have your initial little Q wave there. Then we go up and down. That's how it should look based on the path of the electrical impulse. So that little Q wave, sometimes we look at a Q wave as pathological, as a bad thing, right? Sometimes when we see that, it can be a bad thing. In V5 and V6, it's normal. If you don't have it, it's okay. If you do have it, it can be okay as well. Okay? You guys have any questions about the electrical impulses of the heart? Anything to say, add? No? Was that clear? Did we go through it too quickly? Is it good? Okay. Good. So let's talk about how the ischemia, injury, necrosis, all that stuff should look. Okay? Ischemia. What's ischemia?
Lack of blood flow.
Yep, lack of oxygen. So the heart is just needing to get perfused somehow. Okay? So we're going to possibly see ST depression, right? So this is how ST depression can look in the various leads. Okay? What can we do about ischemia? Give oxygen, yeah. We can give nitro, anything that can open it up to get more oxygen into a specific part of the heart, right? So it is possible to fix ischemia, right? So ST depression, these are the types of things, the times where we're going to see it. Can we do anything about potassium levels? Nope. In fact, we're probably not even going to know that that's the problem. And subendocardial MIs, do we even care if it's subendocardial versus, we don't care. That's beyond the paramedic level, okay? So when we talked earlier about diagnosing things, I mean, we can, kind of banter about like whether we can see it or not. Doesn't matter for us, okay? But this is where sometimes we're going to see it. As far as treatment goes. Yep. Okay, injury. So what would be a type of injury, cardiac injury?
We change from infarction or ischemia to infarction.
Perfect. So the tissue is actually dying, right? Yep. So here's some various types of ways that you guys have all seen out in the field ST elevations look, right? So this one takes forever. I should probably make that shorter, huh? Or the tombstones. Okay. We can see ST elevation in any of these types of patients, right? So obviously this is what we're looking for is the MI patient. Fringe metal angina. We can see an ST elevation. Does anyone remember fringe metal angina? It's basically, it's like a faux heart attack. It's it's not relieved by nitro, it's relieved by calcium. So you take them to the hospital, they get calcium, and it goes away. It's like little vasospasms, is basically what it is. Feels like a heart attack, looks like a heart attack, it's just, they get calcium. Cardiac trauma, including tamponade and pericarditis, that can also show us ST elevation. And we'll kind of show you some of that. Again, kind of doesn't matter for us, but we're going to treat a STEMI as though it's a heart attack until we can prove that it's a cardiac tamponade or pericarditis. Okay? We'll kind of look a little bit more into that in a minute. Okay, so necrosis. Remember when I was showing you the R wave without the ST elevation? That's previously necrosed tissue. That's something that's already happened, nothing we can do about it, that tissue is dead. Okay? So sometimes we're going to get that little deflection, that little negative deflection. Why would we have a negative deflection, that little Q wave, in a lead where we're not supposed to have that little negative deflection? Why would we have that?
The impulse has to
Think
go
about the
around.
electrical pathway that we talked about. So,
The impulse has to go around the dead tissue.
exactly. Yeah, so you're going to get where the electrical impulse normally takes that nice smooth little freeway and perfectly does what it's supposed to do to look the way it does on your paper. Now you have dead tissue, so that electrical impulse is going to hit the dead tissue, but it still wants to get to its endpoint, so it's going to go back around. It's going to find a workaround, and that means the electrical impulse has to go away from the lead and then come back towards it. So yeah, it'll go toward, it'll go back where it came from. Which means it's going away from the positive lead, and then it'll come back to the positive lead. So whenever you have necrosed tissue or a previous cardiac trauma or previous cardiac injury, it's normal to see a Q wave because the electrical impulse has to find a workaround to get back to where it wants to be, right? So that would be an example of necrosis. So again, that's why sometimes we're going to see right and left axis deviations when it should be a normal positive lead deflection, and you get a negative. It's the workaround. The electrical impulse is finding a workaround. Okay. Okay. Standard 12 lead. This is what you guys have. Nice, beautiful, clean. They even put down here lead 2, which we're not going to have. Okay. This is what you guys should have on your little cards here. So, one of the best paramedics that I have ever learned from, pretty much my hero, best guy I've ever known in the entire world, incredible guy. You guys might know him. He came back from San Jose Fire with a neat little thing. He calls it Big Lie, Little Lie, Say All. Okay, so it's a really good thing. It's a little shortcut on how to remember what the leads look like. If you don't have this card and you just want to look at the leads and try to figure out what portion of the heart you're looking at, look at it this way. So starting with the left side, lead 1, lateral, inferior, inferior. Why don't we use AVR? So why is there a big X?
Because it's an inverted lead too.
Yeah, but it doesn't tell us much, right? Because of the location of the electrical pathway of the heart, right? So AVR doesn't tell us much. So because AVR doesn't tell us much, we exit out, forget it, okay? So we drop below that to lateral, inferior, then we go septal, septal, anterior, anterior, lateral, lateral, okay? So big lie, little lie, say all. And I think if you flip your card over, I think it says that again. No, it doesn't. Okay, either way, so you guys get the picture. So that's a good way to remember if you don't have your little cheat sheet on what part of the heart you're looking at. Real quickly, I just wanted to talk about quick looks. Do we all do quick looks out in the field?
Yes.
Yeah, okay. So what is a quick look?
1, 2, 3, AVR, AVL, AVF.
Yep, so it's which leads are we using?
Everything except the main leads.
The standard 3 or 4 leads, right? Yeah. So with that, can we see all types of MIs with a quick look?
You can
We
see
cannot.
many types.
Right. You can see
All but 2.
two types, yeah. But we're not going to see them all, right? it gives us a limited view of the heart. The reason it's important to even talk about a quick look is because why would we be doing a quick look in the first place? Exactly. So if you're doing a quick look, we're all doing a 12 lead, correct? So a quick look is nothing more than while we're setting up for a 12 lead, we're just doing a quick look. So we should never be doing a quick look as a diagnostic performance anyway, right? So if we're doing a quick look, we are doing a 12 lead, right? Everyone should be doing that? Yeah? Okay, good. So we're not diagnosing certain things. We're not looking at anterior septal. So let me show you some examples to beat you guys up with this. So here we go. Look at this left side, quick look. So what does it look like right here? Do we have an inferior MI? Do we see ST elevation anywhere here?
Yeah, one.
ST elevation in 2, 3 and AVF?
Depression, reciprocal
No,
changes.
we don't have elevation there. Do we possibly have elevation in 1 in AVL?
Yeah.
Yeah. So looking at that, we can say we possibly have ST elevation in the lateral leads, right? But look what we're missing too. So anterior septal involvement for sure. So again, look at 2, 3 and AVF, no ST elevation there, right? But if we did a full 12 lead, we'd see that. Okay. You guys want to practice? Okay. So this is what we're looking for. For 12 leads, for ST elevation, we're looking for elevation of, you guys remember how many millimeters? How many small boxes of elevation for the ST segment? It's one small box or 1 millimeter, okay, or more. So if we get one small box or more of elevation, that's indicative of ST elevation, okay? How many contiguous leads do we want to see ST elevation in to make sure that it's actually a heart attack? Minimum of 2, right? Okay, so if we have, if you guys take a look at your cards, okay, if you have, let's say, ST elevation in leads 2 and AVF, but not in 3, is that considered a contiguous lead? We're going to say yes on that because it's looking at the same part of the heart. Okay, so look at, you have ST elevation in lead 1 and V6, but not in V5 and not in AVL. Would that be considered 2 contiguous leads?
Yeah.
Absolutely. Okay, good. So that's all we're looking for. 1 small box or more and 2 contiguous leads. That's it. The way that I personally do this, feel free to do it how you guys want to, but personally this is the easiest way for me, and the reason I do it this way is because on a quick look, you can quickly see it this way. So I always start my 12 lead interpretation this way, with leads 2, 3, and AVF. I always look at that first, okay? The reason I do that is it's standard 4 lead, quick look, you can look at that just real quick and say 2, 3, and AVF, I saw the complete inferior portion of the heart. So 2, 3, and AVF, I look there. Then I go leads V1, 2, 3, and 4. Okay, that's my second step. Okay, so I look at the septal anterior portion of the heart. Okay, third and last step is I look at V5, V6, lead 1, and AVL. So that way you're looking at first step, inferior, second step, septal anterior, third step, the V leads, the lateral sides. Does that make sense? 3 steps, you guys should be able to identify any stem. Okay? Real easy. Let's give it a try. Okay. So let's do this one together just so we can kind of see how we're doing it. Okay? So if we do it my way, we're starting at which leads? Do we see more than 1 small box of elevation? Yeah? So where do we know the ST elevation is right now? Inferior portion of the heart. Perfect. Good. Do we want to stop there? Because we already identified the standard, right? Do we want to stop there? No, because we can have more involvement, right? So then where do we go?
1.
V1, 2, 3, and 4. There's a couple things we're looking for. Remember that R wave that we're talking about? Do we have an R wave? In V1 or V2, 3, and 4, do we have a positive deflection before it goes down?
It's
Yeah,
hard to
so we
see.
got an R
V1
wave.
looks like it does, and I can't really see much in 2 or 3.
It's difficult to see, but it is there in some of them. So because the R wave exists, what portion of the heart do we know is good and intact?
Septal.
Septal wall. Perfect. Good. So do we see ST elevation in V1, 2, 3, or 4?
No.
We should. No? Okay, so we know the antral septal part is good, right? Okay, do we want to stop there? No? So we go where?
1, AVL, 5, 6.
V5, 6, 1, and AVL. Do we see ST elevation in any of the lateral leads? No? Perfect. What do we call this MI? Inferior MI. Perfect. So when we look at, good job, really good job. So when we look at this, we see ST elevation in 2, 3, and AVF, right? So that's an inferior. You guys nailed it right off the bat. Perfect. Then we see what we call reciprocal changes. Okay, it's a super fancy word that basically means mirror image. Okay, so when you guys hear reciprocal changes or you see that, basically what you're looking at is a mirror image. So the inferior portion of the heart is infarcting right now. Okay, so you look at the inferior or the mirror image of the heart, and you get a mirror image of the ST elevation would be ST depression. Okay, so you get a reciprocal change or a mirror image in a different portion of the heart. So if you have ST elevation somewhere, you're also going to have ST depression somewhere else because it's a mirror image. That portion of the heart is getting less oxygen, so you're getting ST depression somewhere else. It doesn't matter for our purposes. Okay, so just remember reciprocal changes, super fancy word, mirror image. It's all it is. Okay. Okay. Someone want to do this? Thanks.
Alright, so 2, 3, and AVF. It looks like we have ST elevation in all 3 of those, so we have an inferior suspected MI. And then we're going to go to V1, 2, 3, and 4. I see a R wave in all of them.
Good.
I don't see ST elevation, so that tells me that section of the heart is good.
Good.
And then I'm going to go to V5, V6, lead 1, and AVL, which also show no signs of ST elevation. So therefore, I see some reciprocal changes, which tells me there's a mirror image of something else going on, and I'm going to suspect this is an inferior.
Nice work, John. Nice work.
Try it.
Or you could have just looked at the interpretation up top and said inferior, right? Perfect. Good job. So that, I'm sure you guys all have your own system. This just works for me, so that's the way I'm teaching it. So feel free to use your system if you like, but this just happens to be the way that I do it. It's the way that John did it. We'd like to, Corey, you want to do this? Sure.